These are going to be recorded sessions, so since they live online, we like to avoid any PHI or PII that could be shown on the slides or discussed. So as you're presenting cases or discussing cases, please keep this in mind. As always, we really appreciate audience participation, so feel free to put questions in the chat or come off mute throughout, and we will get started. Chelsea, I will hand it over to you for our first case.
So I have no disclosures, no financial relationships. I'm not going to discuss anything off label. I saw a young woman in the clinic for her diabetes. She was being seen initially for insulin pump status and use, and she had one, but was having just a little bit of trouble with it. So currently she's 47. I think I initially saw her when she was about 42. She was diagnosed with diabetes at the age of 26, diagnosed with type 1 diabetes. Average BMI, I couldn't find it specifically in the chart, so let's pretend it was about 23. And her diagnosis, A1C, was 7. She did not have DKA at diagnosis. She was just diagnosed on labs. And she had a negative GAD when we tested her. We did not do C-peptide. And her current BMI is 23, but it had been down to 18 for quite a while before and during seeing me. Her current A1C is 6.4, and she has a long history of really well-controlled diabetes on paper, but with her sensor on, her GMI is often higher in the 7 to 8% range. She does have kidney disease, so I think that's what's throwing it off. And her blood sugars are currently in the upper 100 to 200s pretty regularly. So initially,
well, actually, let's stay with that slide for a moment. So
yeah.
if we can, so sometimes we just go with very little information and see, and Tony will jump in here from time to time, and maybe we'll switch who does what on the next case. But there's a lot to say right here, and there's some interesting points. I mean, some companies will not provide, some insurance companies will not support an insulin pump without evidence of type 1-ness. Others, if there seems to be a need, they will cover it. But here, the situation is we don't definitively have type 1 diabetes, and she has a pump. So I don't know if you can speak to that, Chelsea. I mean, that was probably before you saw her that she got the first pump.
Yeah, and I think this was 20 years ago probably that she was diagnosed, right? So they weren't routinely checking for antibodies at that point. They just said, oh, you're young, you're thin, you have type 1. Right. So I don't think there was any question to whether she had type 1. Even when I saw her, I was like, well, you don't have any family history. You seem to fit the mold. Blood sugars are certainly labile enough. It seems like a pretty straightforward thing.
And one of the things that since we've known you a long time, that we advocate for actually definitive testing. One day, I think it will be standard of care, but you see a person like this, and now I would absolutely do antibodies. I would see whether there was any, I say any evidence of anything else in the family. It doesn't have to be type 1 diabetes, but any autoimmunity. We would get a C-peptide, but absolutely there are places where what happened 20 years ago would still happen today. So, but I think the field is evolving, and we look at someone like this and we say, what do you really have, and how can we be sure? So that's some of the things I get even from this information.
Right. And I'm right with you, Dr. Phillipson, which is why we did that antibody.
Oh, I'm sure. I know you are. And as I say, we've known each other quite a while. And it's particularly interesting for a 26-year-old who has normal BMI to say, sort of, I was diabetic. So how did, again, 20 years ago, nobody knows, but if we were to see her today, how does she happen to be diagnosed? I mean, so a 26-year-old with type 1 might actually show up in DKA these days because they had no clue and they didn't really understand what was happening to them. So on the other hand, if they're lucky enough to have a great internist or a family practitioner who does do a sugar from every now and then, maybe it would be caught inadvertently. So as I say, even from this, there's a lot to think about in terms of how we understand diabetes and what's typical and what's not typical. So anything you want to add to that, Chelsea?
Well, yeah, go to the next slide. The only other thing that stood out to me upon seeing her is that she had a diagnosis of lupus as well. So I thought, well, there's autoimmunity here, and she doesn't have a family history. I did also notice that she was wearing hearing aids, and I think I was a little curious about that because I had heard about maternally inherited diabetes and deafness. And when I asked her about it, she said she had hearing loss since a child. And on the chart, it says congenital hearing loss. So then I thought, well, maybe that's not the sensorineural one. And so maybe not. And I really probed her probably every time I saw her. Any diabetes in your family history? None at all? Any? No. So I know it was kind of something we often talked about, but really our main focus was her insulin pump and her ability to use it.
Yeah,
So
absolutely. So, and even at the top, I mean, that's very curious that you say she had alterations in mental status. So even when you saw her, did she have a caretaker or someone in the family was looking after her?
right. So not the first time. We met a few times prior to her mental status alteration starting to happen. She did have a great deal of depression that she was being treated for as well. But her husband would come with her to her appointments. So over time, she ended up having some alterations in mental status, did have some seizures, and then was hospitalized. And they worked her up, and she had, was on various medications over this amount of time, and jumped from our health system to another. And they worked her up pretty a lot. So maybe I'll stop here and go into that other medical history. Let's see. And she said she'd had hearing loss since elementary school, actually, but her primary doctor wasn't that interested in it, not that concerned. She began wearing hearing aids in her mid-20s, though, and her hearing loss continues to get worse to this day. She saw the audiologist just recently, and it's continuing to worsen. Like I said, she was diagnosed with lupus. She did have a positive ANA, so they had a reason to diagnose her with lupus, with some other things in there, but her diagnosis has been since removed from the chart because of her me loss. So this woman has been diagnosed with me loss. She said she has 2.5 out of the 3 things you need to have for me loss. So what is that, like mitochondrial encephalopathy, lactic acidosis, and
Right.
stroke-like activity, right? So she didn't have stroke-like, but she did have seizures.
Well, you said, and it could be very confusing. So it could be that in fact they weren't seizures, they were this stroke-like activity. And so we'd have to, get back to the neurologist and say, really, did you think about this? And then see what they say.
Mhm. So it seemed, they've diagnosed her with MELAS, or that's what everybody seems to be happy with calling it. And since then, she has seen the rheumatologist, and the rheumatologist said, you know what, I don't think you ever had lupus, and we should take that off. I think it was just an incidental finding that you had this positive ANA. And she saw a second rheumatologist who separately said the exact same thing and pulled it from her chart. She has been off the medications for lupus and has not had a recurrence of her of any evidence of connective tissue disease. So they're pretty satisfied with taking that off her diagnosis as well.
That is very interesting. And so, yeah, continue.
Yeah. This morning when I talked with her, she did say, after talking with her mom does now have a diagnosis of type 2 diabetes, but only in the last year. And her mom is now wearing hearing aids, but only in the last year. Hearing loss noticeable for maybe the past 5 or 6 years. So not very long term, nothing that we wouldn't chalk up to old age. A paternal aunt and her paternal grandmother also have type 2, but I don't think that's very relevant.
Well, but I'm going to talk about that. I'm not sure that it's not relevant, but we'll see in a moment.
Okay. She does have a sister who does not have any symptoms, and she has 2 children, none of which have symptoms.
Yeah, I see Kristen has jumped all the way to treatment, but we'll get there. We'll get there in a minute.
Yeah. All right. And then, so here's the genetic talk that I'm not going to be able to speak much to, but I pulled this from not the report, but from the note from the geneticist.
No,
So
it was
Dr.
interesting that you did. So we'll, oh, and do you know when was this done?
I think it was done in 2023.
All right. So it is interesting. And so is there anything else? So I'll jump in and then Tony, you'll jump in too. Okay.
She did have severe hypertriglycerides greater than 1,000 in 2013, but was asymptomatic,
Uh-huh.
and a shunt for portal hypotension.
Oh, that's interesting. Yeah.
And then she has non-alcoholic fatty liver disease and is being treated with that. And that's what they think. I think the ammonia levels are what they're so concerned about with her mental status. And she seems to do better when she is using the bathroom regularly. Oh, one other thing interesting came up. She was to see the eye doctor, and they test her eyes regularly for Paquinil toxicity.
So I'll say a few things. I mean, so there are no children here?
She has 2 teenage children, but neither of them have any symptoms at this point.
All right, but that's very important to know that. Do you, and we'll come back to that in a moment. I mean, so everyone, so let me just back up a little bit and say, it's a fantastically interesting case. We're very interested in mitochondrial disease and diabetes. I gave a talk about it not too long ago at CHOP. There's a mitochondrial disease support group, and which is mostly pediatric neurologists, actually, with a handful of other people. And my new friend Amy Goldstein at CHOP is one of the pediatric neurologist who's interested in that. And then there's Shana McCormack, who's also at CHOP, who is part of that group. And then there's a bunch of people who I've gotten to know recently. And that's exactly what will come back to Kristen's comment about treatment, because some of this is based on clinical studies now that haven't been reported yet. So the thing with all of this is that you get diabetes and deafness, and you think really about 2 things. One would be mitochondrial disease, so MID or MELAS, which weirdly enough is almost always exactly the same mutation. We'll come back to that. And Wolfram syndrome is the other possibility, but clearly, it certainly looks like this is all about the classic mutation. So mitochondria have something like 8 genes in human mitochondria, and there's also many mitochondrial genes in the human genome that contribute to making a mitochondria that we all have in all of our tissues. The particular mutation here, which says M3243-eta-G, is a base change in the gene called MTTL1, which we also know as something called the tRNA for leucine. So mitochondria, being important walled-off organelles in our cells, have their own DNA, and they make their own proteins, at least a handful of them. All the rest are made in the nucleus of the cell. And in order to do that, the mitochondria need to have all the machinery to make a protein, which is what a transfer RNA or a tRNA is. And for some reason, this mutation is a hotspot. So most people who have mitochondrial diabetes and deafness or MELAS have exactly this mutation. So it's weird, but well understood. And we have, I think in our registry, we have now more than 10 families. So that's a little bit about that. We'll come back to what heteroplasmy is also in a moment. Then the other gene that was reported, NDUFAF2, that's an interesting gene too. That's a gene that's made in the nucleus, also a mitochondrial gene, interestingly enough. And it's associated with something called Leigh syndrome, which again, mostly pediatric neurologists might see. I don't think I've ever actually seen a case, because they don't necessarily have diabetes until very late. And that's an interesting thing I only learned recently. But that is a homozygous recessive for the most part. Those people are very sick. They usually die early and have systemic disease. So I don't think the NDUFAFA2 mutation plays a role here, although it's interesting that it's just another mild hit in the mitochondria. So if you have one good one of those and one not good one, you still seem to do okay. The tRNA mutation, not so much. So if you have that, then you will have mitochondrial disease depending on this thing called heteroplasmy. Now, what does that mean? So because you have so many mitochondria in your body, only a percentage of them are actually sick. If they were all sick, you couldn't survive. So All right, so Tony is helping me out here. So 13, oh, of the 37, but so the 37 includes the nuclear genes as well as the mitochondrial genes, Tony, or just the nuclear
No,
genes?
the mitochondrial DNA itself has 37 genes. 13 of them code for enzymes that are used in the mitochondria. Many more of those enzymes are encoded in the nucleus, and then the
And
rest,
I said,
it's
I
really,
said 8, right? So I get,
yeah,
so when I
20.
was,
So there's 24 that
yeah,
for
and
tRNAs.
when I was a child, you know, it was all in one direction. So now we know there's different directions, and so that's how we got from 8 to
When I was little, they had 100,000 genes in the whole
yeah.
nuclear
So
genome. Now they only have
right,
20,000. So
20.
they
So
changed
that
it.
things change. Okay, good. So so the heteroplasmy is what is the percentage of bad mitochondria in a way, but actually based on doing sequencing, in this case from blood, which turns out to be not the right place. So in order to really understand heteroplasmy, you need to look at urine, according to the experts I follow, because that includes all the various components in the body, which the blood may not totally reflect that. So that seems to be a thing that I'm seeing over and over again in the literature. And there are only 1 or 2 companies that do urine mitochondrial heteroplasmy testing. And the higher that number, sort of the higher your burden of disease. So speaking of then testing, my bet is that mom and the maternal, well, so the paternal side actually doesn't matter in this case for mitochondrial disease. So because mitochondria almost entirely, it's like 99.5% come from mom, there seem to be a couple of mitochondria that may be in sperm. That seems to be a new finding as well. But almost all the mitochondria that we get are from mom. And so my bet is that, in fact, mom has a few mitochondria that are not good. And that may account or may not. I mean, the only way to know would be to do testing in her. And you could do some combination of saliva, blood, and urine in mom. But the paternal side, I wouldn't worry so much about. Both of the children of this person with MELAS have, I would say, I would test them, although they may not want to be tested. That's another issue. They could, but it does give you a heads up. They could get a hearing test. They could understand other things. And I would say that that, as I mentioned, the MID and the MELAS are the same gene. So so it seems to be just a question of severity, that it's exactly the same mutation for the most part. I mean, we do now that we're sequencing mitochondria a bit more, and Tony can also speak to this in a minute, we're finding there are other rare mutations that look like MELAS in a lot of ways, but aren't, but they're not in that tRNA, the gene that encodes for the mitochondrial tRNA leucine. I can mention just a couple other things because it's very interesting. We'll have to think about this. As I said, the eye disease, there is this what they call a pathognomonic eye disease associated with mitochondrial disease. So just like the hearing, so the cells in the ear that are mitochondria dependent, and many aspects of brain function accounting for these stroke-like episodes, those things can also cause this very stereotypical eye disease. And that's, I say, published over and over again. There's a nice illustration of that. There's a 2008 paper I really like with Rinky Murphy and Andrew Hattersley that described MID. The eye disease is simply mitochondrial retinopathy. But if it's something else, then maybe it's because of the hypertriglycerides or something else. If triglycerides over 1,000 can cause something called boxcar vascular disease, that's really unusual. But because the triglycerides are so fat and rich, you can see the microvessels of the eye. So it may be that he's talking about that. So without knowing his report, I'm just making stuff up here. I can't be sure. I want to talk about the liver disease for a minute. So one of the things in MELAS, as you remember, is lactic acidosis. So why do you have lactic acidosis? Well, lactic acid is mostly metabolized in the liver. And if the liver isn't working, then you get this syndrome of lactic acidosis, which unfortunately can be fatal if it's not cyclic. And part of that could involve liver disease if the liver is really full of bad mitochondria. So that that may be what's going on here. The only way to know would be a liver biopsy. I'm not sure it's totally worth doing, but if she has liver disease based on a high percentage of bad mitochondria, that could explain everything. Although I have to say, I'm not familiar with such severe hypertriglyceridemia in MELAS, and I would have to, I haven't seen that in any of our patients, and it's possible that it's in a long list of things that I have forgotten or maybe never knew. But I think that's that. And so if MELAS and MID are the same gene, what do we call them? Well, some of this is hysterical and historical. And I don't know that it matters. The thing with MELAS is that you'll notice that diabetes is not part of it. It's mitochondrial encephalopathy, lactic acidosis, stroke-like episodes, and diabetes. And yet MID is mitochondrially inherited or maternally inherited, actually, diabetes and deafness. So how is that possible? And I think it's accidental. And there's not, no one has yet like sort of addressed that directly in a specific review paper. It's buried in discussions of one or the other. But I think the more we know, the more we start sequencing mitochondria in people who look like this, the more we see that these are overlap syndromes, and it's just bad luck, I think, depending on where your mitochondria go. So I'll mention all that. I mean, the lupus is a red herring. I think that many people, especially women, are positive ANA, and it doesn't mean anything, but it certainly can lead you down the road. And, you know, maybe, so Tony, maybe I'll stop talking and then we can come back to Kristen's suggestion of potential treatments.
Yeah, I mean, the only thing I would add, and I know Kristen also has a special interest in mitochondrial disease, but you know, yeah, I mean, I think this nomenclature thing is interesting. I think the way that diseases are named is like the famous blind man and the elephant. So we have many examples of diseases where you have two different diseases caused by, you know, the same gene, and that can happen in nuclear genes, which is much less complicated than this. And that's because, you know, that was what was seen, and it may be even the same variant can cause multiple things, but they're missed. I think in this particular case, yeah, I think it's kind of who sees the patient, what are they surveying for? I think you mentioned, Lou, the idea that if you really look at people with just isolated diabetes, you find a lot more of these and they don't have MELAS. So, you know, and that is also, you know, it is a kind of an evolving issue right now about how we name diseases. We used to name diseases after the person who discovered them. And so like a good example of that is there was a form of muscular dystrophy with, like, you know, childhood, adolescent, young adulthood onset called Becker muscular dystrophy. There was a form called an early onset form called Duchenne muscular dystrophy, and they were two different diseases. And then they found they're both caused by mutations in the same, then Duchenne has is very young onset. So then they found they're both caused by mutations in the same gene. That being said, there's a rough correlation. So certain mutations cause the milder form, and certain ones cause the more severe form. There's other, you know, so there's other examples where there's different types that all turn out to be this, you know. So you know, so the naming, I think, is just it ends up, you know, maybe at some point this will be called, you know, a more modern name would be something like mitochondrial tRNA DNA related disease.
Except that there are so
spectrum.
many. So yeah, we are seeing some other as we're doing more sequencing. And so I would say, I guess we have to wrap up Emily's. So let me spend 2 minutes on treatment, and Kristen might want to weigh in. So it turns out that because the muscle also has a high percentage of mitochondria, they can be defective. What I wanted to point out is that a myopathy and basically loss of muscle mass does increase insulin resistance. So some of the patients that I've seen require spectacular amounts of insulin, which probably doesn't matter. It probably reaches an asymptote, and above that, there's no effect. But people are on hundreds, if not thousands, of units of insulin a day towards if the muscles in the body are loaded with defective mitochondria. Insulin doesn't work very well. So that's a problem. And let me, so Tony's right about that. But Kristen made a very astute point about the treatment with potential amino acids and amino acid-like molecules, citrulline and arginine. So I don't know if you want to talk about that, Kristen. I can say there is a group at Baylor, a pediatric neurologist, and his name has just slipped my mind, who is finishing a clinical trial on people with MELAS but not diabetes, and he's looking at muscle strength in particular with citrulline in particular. The citrulline is an amino acid, weirdly enough, from watermelon. You can buy kilos of it. It's not expensive, but there's a thought that maybe it can help bypass some of the defect from the mutated tRNA. And so far, the data is poor. Similarly, arginine, although I don't know, did you have luck with arginine, Kristen?
So citrulline and arginine are two so one of the clinical geneticists at our institution is an expert on mitochondrial disease. Her name's Dr. Carol Green, and she said that the data is better for citrulline, but she does often recommend arginine as well.
There's a group in Japan that's published about a dozen papers on arginine in mitochondrial disease, and so they're big advocates, and they'll use a whole cocktail of stuff. I think unfortunately, so my reading of literature is that it's marginal at best in terms of the improvement.
I believe she had mentioned that she was on high doses of carnitine. Like if a dose is 1, she takes 8.
Yeah, and again,
don't recall her mentioning citrulline.
Yeah, so the question is, who would be
She was on
prescribing that
arginine
for
too.
her, right? So she probably is seeing a neurologist. There's muscle problems. They throw these things at people. People take alpha lipoic acid. They take, as you said, they take CoQ10. There's a variety of stuff that health food stores sell. I don't think any of them really help here.
Okay.
But neither do they hurt for the most part. So, basically you pee out what you don't need, near as I can tell.
Mm-hmm.
So Tony and Kristen, go ahead.
I just want to add like one thing. I mean, because you said like testing test the kid. And I mean, in general, like you can screen, like I feel like they should be screened regardless. Because you have to imagine, even if they have low heteroplasmy or they're negative, like it doesn't negate the fact that their mom has this and that they are at risk. And so
I was just saying, I totally agree, but keep going.
Oh, no, that's it. It was like that. Yeah, Chelsea, like she has 2 kids and they don't have any symptoms now, but it's possible like that they could develop symptoms later on. And so
and it's possible you haven't looked hard enough. So if you had an ophthalmologist look at their retina, if you had an audiogram, I also worry, one of the families that I saw, the pregnancy was a very difficult time. That woman had congestive heart failure in pregnancy when she didn't have MELAS before. Because there was heart issues with the mitochondria. So every tissue in the body can be affected in MELAS. And there's some recent review articles include parathyroid disease, thyroid disease, and all other endocrine diseases, early menopause. So for all those reasons, Kristen, totally right. I think it's delicate, right? So you have to have someone like Kristen in your group who is a genetics counselor and knows exactly how this can be approached. It can be very sensitive, and depending on how old the kids are, then the parents have to be involved. And this whole thing about how you communicate genetic diseases to other family members can be extremely difficult. We could have a whole session on that, or 10. So anything else, Chelsea? Before we move on, so we have a lot of marching orders if you want to get back to the doctors there.
Yeah, I'll definitely pass the information on. I guess one question that she had wanted to know is, and I think I know the answer, she was kind of wondering, okay, if she has this or because she has this, does that make her more brittle? Is her diabetes worse than it would be? And I said, no, I think it's better than it would be if you had type 1. I think you'd be, then more likely to get DKA and all sorts of other things.
Yeah, I suppose. I don't know that I would. Yeah, I wouldn't trade one for the other.
No.
I suppose if you were telling me which one would I rather have, I might rather have type 1.
Well, yeah, I don't want mitochondrial disease.
No, and it's what I tell the medical students. Your brain is one of your top 5 organs, and they never seem to think that's funny. But I think here, it's an issue, and because it's diabetes is the and part of this disease, and it can be. Anyway, beautifully presented. Thank you so much for sharing it. And I hope I'm certainly available if any of our other doctors want to talk about it, or they can enroll in our registry, or we can send you the information. If she doesn't know, this support group for people with mitochondrial disease, I don't think is well known, but it could be very helpful to her.
Yeah, if you could send me the information on that support group, that would be great. Would you like her to enroll in your study, in your
Absolutely. I
program?
mean, somebody said we certainly want to learn more about mitochondrial disease, and the possibility that Kristen mentioned of using citrulline to see whether it affects diabetes. I don't think that's been really reported in any sort of significant numbers. So depending on how the study at Baylor goes, we may be recruiting people with MELAS to see if we can look CGM and see whether there's any detectable improvement in blood sugar control.
All right. Thank you very much, Dr. Phillipson and others. I really appreciate it.
Great. Thank you so much, Chelsea.
Great. So with that,
So-
we're going to transition over to our second case. Wonderful discussion. Thank you, Chelsea, so much for bringing this case. It's always interesting to discuss mitochondrial forms of diabetes in this group. And now we're going to transition to an HNF1 alpha case. So Dr. Schauer, I don't know, I see you're on in here. So I will hand it over to you because I don't think Brianne's able to join us after all. I know she said she might have had clinical responsibilities. So I'll let you take it away.
Yes. Thanks again for allowing us to present this case, which I will admit maybe is not as complicated as the first one, but I appreciate you guys' input. I'm Reem Shawar. I'm one of the peds endocrinologists at the University of Utah. So my colleague Brianne was the one that actually saw this kid in clinic. And so both of us, I guess, I will be presenting to see if you guys can help with the care of this patient. So our patient is 15 years old and he was just recently diagnosed with diabetes. His BMI is within the normal limits. It's at 18 kilograms per meter squared, which is at the 25th percentile for his age and sex per the CDC growth charts. He presented several months ago with polyuria and polydipsia, no weight change, no real abdominal pain. And because there is a family history of diabetes, the family had checked a glucose and it was elevated. So they brought him to the emergency room. His A1C upon presentation in the ER was greater than 14, and he was not in DKA. So his pH was normal. I don't believe they had checked beta hydroxy or urinalysis to check for ketones, but there was no evidence of acidosis on his BMP. And so we routinely check type 1 diabetes antibodies on all our kids with new onset diabetes, and all 5 of them were negative. So typically what we do is we start our kids on insulin, and as an outpatient, once all the antibodies have resulted, we discuss the results with the family and decide if further intervention or analysis needs to be done. And so at the first follow-up visit, we had received that the antibodies were negative, and we did a random glucose and C-peptide level. This is while he was on insulin, and his serum blood sugar was 76 with a detectable C-peptide at 0.5 nanograms per ml. So currently, he remains on insulin, long-acting and short-acting, a carb ratio and a correction factor. And once the type 1 diabetes antibodies were negative, and I believe the genetic testing had come back, we had started him on glimepiride. It was 1 milligram daily, and then we upped it to 2 milligrams, which is what he's currently on. Again, his BMI remains similar to where he was. There's no concern for overweight or obesity. And his last hemoglobin A1C, which was, I think, several months ago, is down to 9.9. Of note, which I didn't bring up in the HPI part, was that his family history, there is a family history of diabetes like we talked about. So the mom, we suspect, has HNF1A MODY3. Apparently she was diagnosed with diabetes when her A1C was 6.3 and she was started on metformin. I don't believe that she had any antibody testing or genetic testing done. So I will have to say we're just expecting that it's MODY. based on our patient. And then she also mentioned that there is her father, so the child's or our patient's maternal grandfather also had diabetes, and we're suspecting it likely was MODY as well. So like I said, after we got the negative antibodies, we had proceeded with genetic testing, which did show that he had a pathogenic heterozygous variant in HNF1A as below, which is associated with MODY3. Mom was just diagnosed.
Why don't we actually stop there for a second? I mean, I don't know, Tony, do you want to sort of expound on this a little bit? And then I see Chelsea was saying, so the mom was just diagnosed and she was, what, 30, 40 something?
She is, I don't know her exact age, I'm sorry, but it was just a year ago. So I'm assuming, yeah, maybe in the 30s, 40s.
And you say that she has one alpha mute, but she hasn't been tested yet.
Correct. I think that may be a typo. I don't think that
Okay.
it was, yeah, I don't believe she's been confirmed
Well, we
genetic
agree with you,
wise.
but we'll come back to that. So I don't know if, because I think there's a lot here to say, Tony. I mean, so
Yeah, I mean, I get, I'm not sure what you kind of had in mind, but, and, you know, in terms of the mom, yeah, I mean, I would have just, I would have definitely just said mom has diabetes. I'm not, it's not clear why she got a diagnosis at 6.3.
Yeah.
And you also, I think you also kind of don't want to assume that I would not assume that that's what she had. Because we're often wrong because diabetes is so common. So it's possible she has something else. I guess if she's, you know, it sounds like it sounds like what you really want to say, what it sounds like is that it sounds like she has the phenotype and she's likely to have the variant. Is that it sounded like you're getting something specific, Lou? I don't know. And then I guess the maternal grandfather,
is,
like what?
Yeah, I was just say what the specific thing is, I would say metformin is like totally the wrong therapy.
Right, yeah. Well, yeah,
I'm very biased about that, and yet I'm
Yeah.
confused why he's not even doing better than he is on the glimepiride. So we'll come back to that in a moment as well.
Right, the child, yeah, and then I guess the other thing, the maternal grandfather, yeah, again, I would, you know, want to hear like why do you think what was his phenotype, like when did he present, and what was he treated with, and what would be helpful to just have kind of going into the testing. But now you have the answer in the proband, in the patient.
Right. In the patient.
And Tony, could you, so we have a very interesting,
Yeah.
you know, mutation. So, you know, that's what your group does. So
Right. So yeah, so this variant, I think this is in, yeah, so it really should say pathogenic, and it's heterozygous. And so what this is saying is, you know, these are the variants that often cause MODY, where, you know, there's the DNA is, you know, DNA is read by the cell in threes. And so if you delete, you know, so as Kristen notes, it's one of the most common HNF1 alpha variants, I think, or it's a variant of one of those. So if you delete one of those, you shift over the reading frame. And so what you end up with in this case is that one of the variants, or the variant that the person has, would predict that they just don't make any HNF1 alpha from that. So they only have one functional copy. But the classification of this is not just based on that, because then you also have to have other evidence. So this variant has been shown that there's lots of cases with it. I believe this is the one that, you know, there are lots of cases with it, and although 865 is not, yeah, I don't know. Anyway, there are lots of cases with it. It predicts no protein, and you don't generally, the pathogenic ones, you're not finding a lot in the general population, and there's, you know, so those are some of the clues that we use to figure out whether a variant is actually pathogenic.
Yes.
All right,
And then I guess the only thing to say kind of to be helpful is, if you ever if you ever do testing and you get it back and it says it's a variant of uncertain significance, you can actually send it to Kristen and me, because we run a worldwide effort to curate as many of the variants in these as possible. So often the lab might not have all the information. So if you get an ambiguous result, then please feel free to send it to us. So this was an unambiguous one. So
Appreciate it.
So let's see. Oh yeah. So okay. So there's lots here. I mean, so we have you know, a child with high blood sugars, low BMI, negative antibodies, low C-peptide, family history, although after the fact perhaps, of diabetes. Kristen is asking about SIBs. So there were no SIBs for this child.
I will admit, I think he has siblings. I'm not 100% sure, but none of them have diabetes as far as we're aware.
And then the question is, none of them have diabetes yet. So
Correct,
the
yeah.
issue is that, you know, what is the age of onset? That's a very interesting research question. So in the 200 odd folks that we have with HNF1 alpha in our registry, we have a growing number of children who have a completely highly penetrant mutation like this one, who don't yet have diabetes. And then if you look to see onset, obviously, I mean, he was, what did you say, 15? So we see in some cases children as young as 8 or 9, and in some cases is into their 20s. And in fact, the definition was diabetes before the age of 25. So all of that's good. So if we can, so the next slide, as I say, I'm still concerned that, yeah, so it's very interesting. I mean, but most of the people that, here's the thing, that take the medicine do way better very quickly. Yeah, I mean, I found that even in glimepiride, so what's interesting, and I think series on, we have some other pediatricians here, with glyburide, some of the kids, especially with neonatal diabetes and different mutations, it seems to be more rapidly metabolized. So there's no real data on glimepiride in this group, but it's not impossible that taking it twice a day would be better. That's where the CGM patterns would be incredibly helpful. You know, if he's taking it in the morning and it wears off by dinner, you know, then you can see maybe twice a day glimepiride might be better. But usually they do very well with low doses. I mean, even, you know, classically, these people get hypoglycemia in the beginning with even 0.625 of glyburide, and glimepiride is a little bit stronger. Now, did you say he still needs insulin?
He is still on long-acting 10 units. The doses that are written are still the same. Now,
So I would say that's a problem. So as long as he's on insulin, the beta cells are not being fully stimulated. So you might want to figure out how to withdraw the insulin, sort of bite the bullet, take our word for it, that if in fact we're right about all of this, that the glimepiride will kick in much better even without the 10 units. So you could gradually withdraw the insulin, use the CGM to guide you. And then more recently, Tony, I think I was mentioning, some of our colleagues are starting people, although not necessarily 15-year-old, immediately on GLP-1 agonists and not even using sulfonylurea. So that's not a thing yet in the literature. There's no paper that says, you know, we should be doing that instead. But we certainly in our group, we have been adding GLP-1 agonists to people who are not doing great with sulfonylureas alone, that can help them avoid or get off of insulin. You don't need to use Ozempic and Mounjaro. I think, you know, the older agents will work. There is a paper over 10 years ago now from Denmark using liraglutide in people with 1 alpha. It was like just an N of 10, sponsored by Novo in that case. And that would be, and that showed efficacy, although nothing much came of that. So you could use liraglutide or any available GLP-1, since it's hard to get the newer ones. But I think that's part of what I would do. And that also, you know, makes you think about mom. You know, why metformin, you know, works on the liver for the most part, although actually my sense is no one actually knows how metformin works. But because the defect here is lack of insulin secretion, it does seem to me that metformin is not directed at what the problem is. And the sulfonylureas will help to stimulate insulin secretion and help to make sort of happier insulin secreting cells. So that's what I would say so far. But let's go to the next slide for a minute, because we only have like 12 minutes here. I think there's more. Yeah, okay. So we talked about the sulfonylureas a little bit. And so just clinically, our experience is that most people will start on glyburide. In Europe, it's called glibenclamide, same stuff. I tend to use that just because the papers go with that. In some cases, we've switched to glimepiride because there are fewer pills. I mean, glyburide maxes out at 5, although again, with HNF1 alpha, they should respond to that. And the max dose, I mean, if they're, you can go to 4 or even 8 of glimepiride, but if they're at 4 and not doing well, something's wrong. So either they're not taking it, or, he's eating 400 or 500 grams of carbs a day, or something. So I would investigate that a little bit more. Yes, the A1C is almost always less than 7 by the time you get things organized. I'll mention that. I'll mention just that the answer to all this screening is unfortunately yes. I mean, I think the issue is for me that depending on his compliance, and what's happened to him when you saw him, I mean, he's not free of complications. What's interesting, I always love mentioning the effect on renal sugar excretion. So because HNF1 alpha controls SGLT2 expression, the kids can often be diagnosed just by measuring sugar in the urine, which will be positive way before they have any blood sugar elevation. So the SIBs could be checked with just urine testing. And if they have sugar in the urine, they probably have the gene and could be confirmed. I think Dr. Greeley may have a couple comments too.
Yeah, no, this is a great case, and thank you for bringing it up. And I guess just a couple of things are that we have seen in adolescents who are kind of peripubertal that sometimes the sulfonylurea response is not quite as immediate and obvious and as robust as it's been described in the literature. And we don't really have a lot of data on it yet. It's kind of more anecdotal, but we think it's probably related to, insulin resistance around that time. But I certainly agree with Lou about encouraging you to probably stop the Lantus like soon. And given the A1C now being improved and the C-peptide production, it's extremely unlikely that the patient will have a bad outcome from stopping the Lantus. Whereas if you get to a point where the sulfonylureas are really working and you have the Lantus on board, you have the increased risk of the hypoglycemia that can happen with those agents. And that, by the way, I think is part of why some people elect to do the pump, is that there can be kind of relatively quick ups and downs. And so there, and hypoglycemia is possible, but it's kind of a matter of finding the right dose. And I think the majority of people, like in the literature in the Exeter group, have described most people are happy to just take a few pills. They have a little bit of ups and downs, but they mostly don't have to worry about it, and they're not tracking their blood sugars carefully. But as Tony mentioned and as Lou mentioned, you'll occasionally have people who really want that control, and then an insulin pump is a reasonable way to do it if that's what they want to do. But I also want to emphasize that metformin, there was even an Exeter did an actual randomized controlled trial of metformin versus sulfonylurea in HNF1 alpha to prove that metformin really does not help these patients. Now, that being said, these adolescents and the insulin resistance, like theoretically, that could be something to consider, but we don't really have enough data. If anyone is even modestly overweight, and especially if they are obese, though, I think that's where the GLP-1s are an especially good choice, but probably still as an adjunct rather than a starting point. That's kind of, I think, how most of us are looking at it.
Yeah.
And the last thing I will say is that after we did this precision medicine diabetes initiative thing with all these systematic reviews, what I learned from that was that these patients actually have a pretty high risk of cardiovascular morbidity and possibly even ultimately mortality. And I think my impression is some providers, when they take a family history and they hear about people having, diabetes complications or cardiovascular problems, they might be more inclined to think they're type 2. But in fact, the HNF1 alpha and 4 alpha really do have those complications as a possibility. So, never, I would never want anyone to rule out the possibility of MODY based on that. And we don't really know much about how best to prevent it, except we think, good glycemic control and good following with your doctor about, and making sure the doctors and providers know about that risk so that they're monitored appropriately and the cholesterol levels and everything.
Yeah, Tony, go ahead.
Yeah, I just want to add regarding the testing about, that Lou, you talked about, like, that they'll have like the glycosuria before they have diabetes, but just something that people kind of consider when thinking about testing children is, if they're not yet having any evidence that they're affected, then if they're very young, like before prepubescent, there may be there may be some pause to be considered in testing them, because once something's on somebody's record, and if they then end up never getting diabetes, then so it's just something to kind of think about in light of when the onset usually is, but then you also have to weigh in other factors like how comfortable people are with particular families are with uncertainty versus and then what's in the interest of the kids. So just things to think about with genetic testing in general for children.
Absolutely. But it is interesting what Siri said, and I think the emphasis is on giving these people a statin, even if their cholesterol is normal, because there are some unmeasured, some early papers in mice from 2001 and 3, I think from Marcus Stoffel in Chicago at the time, suggested there was some minor lipid moieties made in the liver that could contribute to long-term cardiovascular disease. So I think that's something also to think about.
One more quick thing is that in regards to the genetic risk Tony mentioned, they might rather want to opt for research-based testing, which we could do through the registry potentially, and as long as we make sure their providers are aware of their wish to not make their result a part of the medical record right away, that's an option. And Tony is absolutely right about if you get variants of uncertain significance, you can contact them. But if you get them as part of the registry or reach out to us too, we're part of Tony's group, and when we also can check in about that data. So basically, we're all here to help. And so if you ever have any cases, we're very glad to have them. And the other reason to join the registry, by the way, is we also sometimes have research studies and things that they can participate in. So we certainly encourage that.
Yeah, I can end with, so it's a plug. So right now, and Tony knows, I think some of the other people know, we're starting up a kind of a consortium of groups that have registries or are interested in starting a registry in their own place for any monogenic diabetes. And so that way we can increase the N's and do the studies that we're talking about and try to fill in all the gaps here, which we probably never will, but at least we need to make a stab at understanding, what are the best treatments, what are the age of onsets, what is the outcomes in a longitudinal way, not just taking a slice of life. So I would say that. And what's one other thing I was going to say? And more cascade testing. So it's possible that there are other family members, on the tree from the grandmother. So one of the things to ask, you're seeing the kid. So who's the internist that's seeing the mom? Does mom have SIBs? And does mom have cousins who may, also think they have type 2, but gee, they're thin, and their doctor always scratched their head. So I think that is something also to mention. And as Tony said, it's a burden. Some people don't want to know. And I don't think we have like a standard playbook on how to engage other family members in a way that doesn't put the burden on the people who have the disease.
Right. There are some ways being looked at of, you know, how can you, because some people actually they would like it if you bypass them and just talk to them because of what you said. So that's an issue that's sort of being explored in genetic testing in general about sort of what's the best way to communicate that.
But it makes our ethicists crazy, you know, you know, so we worked very closely with someone who used to be here in Chicago, who's at Rochester, Lainey Ross, who writes a lot about ethics and medicine and you know, exactly how you contact somebody who, you know, you can't just cold call them. It's not, you can't do that. So we need to figure it out. That's any other questions, do you think, we didn't go over? I mean, there's always something.
Yeah, just to remind people that are here for ADSES that we have a separate follow-up procedure for claiming credit from the one that's posted here.
Okay. So yeah, great case. And, you know, should you have others or other questions, we're always available. This is really floating our boat. And as we said, if the family would like to join our registry, if they haven't already, you know, then we can walk through them. And so there's informed consent. They don't have to come to Chicago. The testing has already been done in this family, but we have demystification conversations with the parents. We can do webinars. There are family meetings. We have other resources that they may be able to take advantage of.
Oh, perfect. I will be seeing them in a couple of weeks, so I'll definitely bring that up. I appreciate you guys' help. Thanks.
All right.
Thank
Well,
you.
this is great. Thank you to everyone. Emily, you can wrap up.
Yeah, thank you everyone for joining. I know we're a little bit beyond time, so I appreciate you sticking around. Just to note that our next session will be on the 15th of May, same time, same place. We do have cases booked for that time, but we are always interested in interesting monogenic cases. So please feel free to email our team and we will certainly schedule those for the future. We will be taking a hiatus in June since that is the time of ADA scientific sessions, but then we'll plan to return in July with those dates being announced, hopefully during our May session. The recordings are also available online. I'll be sure to follow up with everyone with the link for those so you can access those easily. Thank you guys. What a great discussion.
I really want to thank Tony and Kristen for being so critical to our session today and in the future and in the past. So thank you. And we'll talk.
Thank you for having us. Take care.